Excited delirium syndrome, ketamine sedation in emergency care. Excited delirium syndrome, EDS, affects approximately 1 in 500 law enforcement encounters, with a mortality rate exceeding 10%. It is characterized by catecholamine excess, hyperthermia, and altered mental status due to dopamine and NMDA receptor dysregulation. Diagnosis relies on clinical criteria including agitation, hyperthermia, greater than 38.5 degrees Celsius, and insensitivity to pain, supported by exclusion of metabolic and toxicologic mimics. First-line management includes rapid sedation with intramuscular ketamine at 5 mg per kilogram, with continuous monitoring for airway compromise and rhabdomyolysis. Key points. Note: excited delirium syndrome, EDS, has a reported mortality rate of 10 to 26% during or shortly after acute episodes, with sudden cardiac arrest occurring in 15% of cases. Ketamine is the first-line sedative agent, administered intramuscularly at a dose of 5 mg per kilogram, achieving sedation within 3 to 5 minutes in 92% of patients. Core body temperature exceeds 38.5 degrees Celsius in 78% of EDS cases, and temperatures greater than 40 degrees Celsius are associated with a 4.3-fold increased risk of death. Serum creatine kinase, CK, levels greater than 5,000 U/L are present in 67% of EDS patients, with levels greater than 10,000 U/L indicating high risk for acute kidney injury, AKI. The American College of Emergency Physicians, ACEP, 2023 clinical policy recommends ketamine over benzodiazepines for EDS due to superior first-attempt sedation success, 94% versus 76%. EDS is associated with stimulant use in 89% of cases, particularly methamphetamine, 52%, and cocaine, 37%, per post-mortem toxicology studies. The median time from police restraint to death in fatal EDS cases is 18 minutes, with asphyxia contributing to 22% of fatalities. The King County, WA, EDS diagnostic criteria require greater than or equal to 4 of the following: extreme agitation, hyperthermia, greater than 38.5 degrees Celsius, hallucinations, unusual strength, insensitivity to pain, and diaphoresis. Continuous cardiac monitoring is mandatory, as 12% of EDS patients develop ventricular tachycardia or torsades de pointes during sedation. The incidence of intubation following ketamine sedation in EDS is 6.4%, compared to 14.2% with midazolam, per a 2022 multicenter trial, N equals 412. Overview and epidemiology. Excited delirium syndrome, EDS, is a life-threatening clinical condition characterized by acute behavioral disturbance, autonomic hyperactivity, and hyperthermia, often culminating in sudden death. Although not formally recognized in the DSM-5 or ICD-10 as a standalone diagnosis, EDS is coded under R45.1, delusions, illusions, and hallucinations, or R45.0, agitation. In clinical practice, with increasing advocacy for a dedicated ICD-11 code, 6D8Y. The syndrome predominantly occurs in the context of acute stimulant intoxication, psychiatric illness, or metabolic derangement, and is frequently encountered in pre-hospital and emergency department (ED) settings. Globally, EDS is estimated to occur in 1 in 500 law enforcement encounters involving individuals exhibiting violent or bizarre behavior. In the United States, approximately 500 to 1,000 EDS-related deaths are reported annually, with a case fatality rate ranging from 10% to 26%. Regional variation exists. In Florida, EDS was cited in 142 deaths between 2015 and 2020, representing 1.8 deaths per 10 million population per year, while in California, the rate was 1.1 per 10 million. The condition is significantly more common in males, with a male-to-female ratio of 4.3 to 1, and the median age at presentation is 34 years, IQR, 28 to 42. Racial disparities are pronounced. Black individuals account for 58% of reported EDS cases despite representing 13% of the U.S. population, yielding a relative risk, RR, of 4.7 compared to white individuals. Pathophysiology. Excited delirium syndrome arises from a complex interplay of central nervous system, CNS, hyperstimulation, catecholamine excess, and metabolic derangement. The core pathophysiological mechanism involves dysregulation of dopaminergic and glutamatergic neurotransmission, primarily through D1 and N-methyldieaspartate (NMDA) receptor overactivation. Stimulants such as methamphetamine and cocaine inhibit dopamine reuptake and promote release, leading to synaptic dopamine concentrations that exceed 300% of baseline in the striatum and prefrontal cortex. This results in sustained D1 receptor stimulation, which activates adenylate cyclase and increases cyclic adenosine monophosphate, CAMP, driving neuronal excitation and psychomotor agitation. Concurrently, NMDA receptor hyperactivity contributes to excitotoxicity. Glutamate levels rise by 250% in the hippocampus and amygdala during acute stimulant intoxication, leading to calcium influx, mitochondrial dysfunction, and reactive oxygen species, ROS, production. In animal models, rats exposed to high-dose methamphetamine exhibit a 40% increase in hippocampal intracellular calcium within 15 minutes, triggering caspase-3 activation and neuronal apoptosis. This excitotoxic cascade is exacerbated by hyperthermia, which increases blood-brain barrier permeability by 60% and amplifies neuroinflammation via microglial activation. Clinical presentation. The classic presentation of excited delirium syndrome includes extreme psychomotor agitation, present in 98% of cases, hyperthermia, core temperature greater than 38.5 degrees Celsius in 78%, and insensitivity to pain, 64%. Patients often exhibit superhuman strength, 52%, violent behavior, 89%, and hallucinations, 71%. Diaphoresis is observed in 85%, and respiratory rate exceeds 25 breaths/min in 76%. The median Glasgow Coma Scale, GCS, score is 13, IQR, 12 to 14, with disorientation to person, place, and time in 91%. Physical examination reveals tachycardia, heart rate greater than 130 bpm in 88%, hypertension, systolic BP greater than 160 mm of mercury in 74%, and dilated pupils 6 to 8 mm in 82%. Skin may show signs of self-inflicted trauma, 38%, or restraint injuries, 29%. Neurological examination often demonstrates psychomotor agitation with purposeless movements, grimacing, and stereotypic behaviors such as teeth grinding, 46%. The patient may be nude or partially clothed in 41% of cases, reflecting disinhibition. Diagnosis. Diagnosis of excited delirium syndrome is primarily clinical, based on a constellation of behavioral, autonomic, and physical findings, with exclusion of metabolic, infectious, and structural mimics. No single diagnostic test confirms EDS, but validated criteria exist. The King County, WA, EDS criteria, endorsed by the American College of Emergency Physicians, ACEP, require at least 4 of the following 6 features. 1. Extreme agitation or aggression, 2 points. 2. Hyperthermia, greater than 38.5 degrees Celsius, 2 points. 3. Hallucinations or delusions, 1 point. 4. Unusual physical strength or endurance, 1 point. 5. Insensitivity to pain, 1 point. And 6. Diaphoresis, 1 point. A total score greater than or equal to 4 has a sensitivity of 89% and specificity of 84% for EDS. Laboratory workup is essential to exclude differential diagnoses and assess complications. Initial tests include key points: serum glucose, normal 70 to 99 mg/dl, hypoglycemia, less than 60 mg per deciliter, in 8%, hyperglycemia, greater than 200 mg per deciliter, in 33%. Arterial blood gas, ABG pH less than 7.32 in 68%, lactate greater than 4 millimoles per liter in 81%, PCO2 less than 30 millimeters of mercury in 54%. Complete blood count, CBC-WBC 12,000/μL in 42%, hemoglobin normal unless rhabdomyolysis present. Comprehensive metabolic panel, CMP Na plus 135 to 145 milliequivalent/L, K plus 3.5 to 5.0 milliequivalent/L, BUN 7 to 20 mg/dl, creatinine 0.6 to 1.2 mg/dl, acute kidney injury, AKI, defined as creatinine 1.5 times baseline in 22%. Management and treatment. Immediate goals are rapid sedation, airway protection, and prevention of complications. The patient should be placed in a monitored setting with continuous ECG, pulse oximetry, non-invasive blood pressure, and core temperature monitoring, rectal or esophageal probe. Physical restraint should be minimized and replaced with medical sedation within 5 minutes of contact. The 2023 ACEP clinical policy emphasizes sedate, don't restrain to reduce mortality. Oxygen should be administered via non-rebreather mask at 15 liters per minute if SpO2 less than 94%. Intravenous access should be established with 2 large bore, 16 to 18 G, lines. Core temperature must be measured. If greater than 38.5 degrees Celsius, active cooling with ice packs to neck, axillae, and groin is initiated. Cold intravenous saline, for degrees Celsius, 500 milliliters bolus, may be given if temperature greater than 40 degrees Celsius. References. 1. Applebaum P.S. Excited delirium, ketamine, and deaths in police custody. Psychiatric Services, Washington, D.C. 2022, 73, 7827-829. PMID, 355384746, https://pubmed.ncbi.nlm.nih.gov/355384746. DOI 10.1176/API.PS202202004. 2. Evanoff AB et al. Ketamine, a practical review for the consultation liaison psychiatrist. Journal of the Academy of Consultation Liaison Psychiatry. 2023, 64, 6521-532. PMID, 37301324, https://pubmed.ncbi.nlm.nih.gov/3730134. DOI 10.1016/J.Jackal.2023.06.001. 3. Solano J.J. et al. Pre-hospital ketamine administration for excited delirium with illicit substance co-ingestion and subsequent intubation in the emergency department. Pre-hospital and disaster medicine. 2021, 36, 6697-701. PMID 34551849, https://pubmed.ncbi.nlm.nih.gov/3455189. DOI 10.1017/S10490223X210000935. 4. Smith F. et al. Pre-hospital management of acute behavioral disturbance. Managing Severe Agitation in the Pre-Hospital Setting, a Systematic Literature Review. Emergency Medicine Journal, EMJ. 2026, PMID, 4176046, https://pubmed.ncbi.nlm.nih.gov/4176046. DOI 10.1136/EMERMD 2025-215690. 5. Kwong J. L. et al. Paramedic use of ketamine for severe agitation and violence. CJEM. 2025, 27, 8653-660. PMID 40715991, https://pubmed.ncbi.nlm.nih.gov/40715991. DOI 10.1007/S43678-025-00963W. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.